Hello and welcome back to AP Psychology. I'm Miss Lee and this is the final video in Unit 8. In this video, we will be evaluating the psychotherapies that we discussed in our previous video. By the end of this video, you should be able to compare and contrast the different treatment methods, including individual and group therapy, rational emotive method of therapy, psychoanalytic or psychodynamic method, client-centered, cognitive, behavioral, sociocultural method, biopsychosocial, and the cognitive behavioral method. If you haven't done so already, go ahead and grab your notes and let's get started. So the question here is, who do people turn to for help with psychological difficulties? Community mental health specialists provide the largest outpatient psychotherapies out there. You're looking at mental health specialists, physicians, and other professionals such as clergy members. Within the psychotherapies, cognitive therapies are most widely used, followed by psychoanalytic and family or group therapies. But first, let's see if we can decipher these questions. Researchers have sought to answer the question, does psychotherapy work? Generally speaking, the answer seems to be yes, people in therapy improve more than people in control groups. Yes, but people in therapy improve at the same rate as people who are receiving placebo treatments. No, therapy does not provide any benefits. People who just let time pass improve at the same rate as people in therapy. And no one really knows because so far the only method used to answer this question has been interviewing former therapy clients. Hopefully you should be able to answer this question by the end of this section. If you ask clients about their experiences of getting into therapy, they tend to overestimate its effectiveness. Critics, however, remain skeptical. Clients enter therapy in crisis, otherwise they wouldn't be in therapy, and crisis may subside over the natural course of time. There tends to be a regression back to normalcy. Clients may need to believe the therapy was worth the effort, so there's kind of a bias there. And clients generally speak kindly of their therapist because the therapist has gone to some length to build a healthy relationship. Like clients, clinicians believe in the therapy's success. They believe that the client is better off after receiving the therapy than not. Clinicians are aware of failures, but those of other therapists. If a client seeks another clinician, the former therapist is more likely to argue that the client has developed another psychological problem or is resistant. Clinicians are likely to testify to the efficacy of their therapy regardless of the outcome of treatment. So it's very hard to kind of extrapolate the bias in both of these perceptions. Outcome research is available, however. Eysenck, you may remember, suggested that 2/3 of clients improve whether they receive therapy or not. He only had 24 studies to analyze, and there were very few forms of psychotherapy available at the time. Today, there are hundreds of studies demonstrating the efficacy of psychotherapy. Mary Lee Smith, back in 1980, analyzed 475 studies and showed that the average therapy client ends up better than 80% of untreated individuals on waiting lists. In general, those not undergoing therapy improve, but those undergoing therapy are more likely to improve. 80% of untreated people have poorer outcomes than the average treated person. Different therapies are most effective in treating certain disorders. Depression tends to respond better to behavior, cognitive, and interpersonal therapies. Anxiety tends to respond to cognition, exposure, and stress inoculation. Bulimia is usually treated best with a cognitive behavioral approach. Phobias are typically best treated with behavioral approaches. Therapists treating bedwetting tend to use a behavior modification program. But which type of therapy is best? No one type of therapy has been found to be superior in all cases. There also appears to be little, if any, connection between the clinician's experience, training, supervision, and licensing to their clients' outcomes. Therapy is most effective when the problem is clear-cut and specific. And psychotherapists are striving to tailor specific treatments to specific problems, so it's very individualized. Alternative psychotherapies include therapeutic touch. The therapists move their hands a few inches from the client's body, attempting to push energy fields into balance, and this does not seem to really work. Eye movement desensitization and reprocessing, or EMDR, is having people move their eyes back and forth while remembering traumatic experiences. The body of research with EMDR is growing, and there does seem to be some relief from the symptoms here. Light exposure therapy is used very successfully with people who have seasonal affective disorder, or SAD. This is a form of depression that has been effectively treated, and this form of therapy has been scientifically validated. So let's talk about the different types of therapists and their training. There are clinical psychologists, mostly PhDs. These are experts in research, assessment, and therapy. And in order to become a clinical psychologist, you have to have a PhD, which is supplemented by a supervised internship, a lengthy supervised internship. There are also clinical or psychiatric social workers. These are people who hold master's degrees of social work plus postgraduate supervision. These programs prepare some social workers to offer psychotherapy, mostly to people with everyday personal and family problems. There are counselors, including pastoral counselors, abuse counselors, and licensed professional counselors. They work with problems arising from family relations and substance abuse and with their spouses and families and child abuse. Psychiatrists are physicians who specialize in the treatment of psychological disorders. Not all psychiatrists have an extensive training in psychotherapy, but as MDs, they can prescribe medications. Peruvian folk wisdom would say it is better to prevent than cure. Preventing psychological disorders means removing the factors that affect the society. Factors like poverty, meaningless work, constant criticism, unemployment, racism, and sexism. That would be really nice. Advocates of preventive mental health programs argue that many psychological disorders are due to social conditions. To prevent such disorders, we should change oppressive, esteem-destroying environments into more benevolent, nurturing environments that foster individual growth and self-confidence. To sum up, a successful intervention can use a variety of methods because disorders are biopsychosocial in nature. There are biological considerations. So biomedical techniques, including drug therapy, ECT, RTMS, and on very rare occasions, psychosurgery, may be used to correct malfunctioning brain circuitry. For example, a patient diagnosed with bipolar disorder with mood swings from depression to mania might be given a prescription for drugs that would reduce the dramatic mood swings. Psychological considerations. In this area, the therapy may help clients gain insight into patterns of thinking and behaving that are causing them distress and leading to dysfunction. The client with bipolar disorder might be helped to recognize the patterns of relationship damage caused by her mood swings and to develop ways to improve her relationships with family and friends. And then last but not least, there are social cultural considerations. Therapy can help people relearn more adaptive responses to the social and cultural influences in their environment. To be more effective, all types of psychotherapy need to be sensitive to cultural differences in the clients being treated. The client with bipolar disorder might be trained to recognize the settings and symptoms of her mood swings and to respond in ways that help her retain a healthier balance. And that is it for clinical psychology. In our next video, we will begin the new unit, the final unit, social psychology. I can't wait to see you then. Bye for now.